Hi everybody. Today I want to do a brief overview of the components associated with Chapter 22 and the obstructive respiratory system disorders. So I want to highlight the ones that are key for you to take a look at when preparing for your test. And in particular, the major topic is going to be COPD, looking at chronic bronchitis and emphysema. So in Chapter 22 with the obstructive respiratory disorders, when we're saying obstructive, we're really talking about disorders that are affecting something to do with the actual tube, causing resistance for airflow, preventing good gas exchange from occurring because air can't get through to where it needs to go in order for gas exchange to occur. So you can see that this occurs from a variety of conditions. So for example, conditions in the wall of the lumen. Things like chronic bronchitis or asthma, where you have inflammation, or in cystic fibrosis, where you have excess mucus, or in emphysema, you get destruction of the walls of the alveoli, which is what you would see there in that third option, obstruction of the airway lumen. Obstruction resulting from increased pressure around the outside of the airway lumen. This can happen as well in some of the obstructive pulmonary disorders, not so much the ones that I have you focus on, but some of the other ones in this chapter as well. So if we look briefly, starting with asthma. Most people are familiar with asthma. Either they have it themselves or a relative, or they know somebody that has it because it's relatively common. You can see, based on your 5th edition of your textbook, it says 5 to 12% of the U.S. population. More common in areas, for example, where there is a lot of airway pollution and such, but there are other components as well that can lead to or exacerbate asthma also. Basically, what you have is a disorder that's causing inflammation of the airways, excessive inflammation of the airways. And it says here that that obstruction that occurs because of that swelling of the airways due to inflammation is reversible, but not completely. It depends on how well that this asthma is managed, because as we did back with Chapter 9, looking at inflammation, chronic inflammation leads to fibrosis, leads to scar tissue. Scar tissue is irreversible. So once scar tissue is formed, that's it. It is no longer reversible. But as long as the airway has sufficient time to heal and recuperate, then the damage that may have occurred is potentially reversible, which is why it's important for someone who has asthma to be on medications to help manage that condition to prevent the development of scar tissue, because it is possible for someone who's an asthmatic to develop COPD if that asthma is not well managed and is severe enough. And you can see how common this is, especially common in children. You may have it as a child, you could grow out of it. You may not have it as a child, and you may develop it as an adult. So there are a few different ways that you can end up with getting asthma. 2 basic types associated with asthma: the intrinsic form, which is the one that you get as an adult, which could be related to exposure, or it could be due to other triggers that suddenly turn on your airway's responsiveness and cause it to trigger this inflammatory response. Or the one that people are more familiar with, which is the extrinsic form that people usually get starting as a child. They may or may not grow out of it, and is often associated with more allergic type conditions. So exposure to dust and other allergens can trigger an asthma attack to occur. So if we look at allergic asthma in a little more detail, because that's the one that people are more familiar with, you can see that as a result of being exposed to these allergens that are irritating the airway, it's going to change some of the components of the epithelial tissue that line the respiratory tract. And in particular, what you get is an increase in the number of goblet cells that are present, causing an excess production of mucus. You get more fluid coming out during the inflammatory process, so an increase in inflammatory exudates, and the airway can become very responsive to even small components of the presence of that allergen. So small amounts of dust or pet dander or things like that could potentially trigger a major asthma attack to occur. So what you're basically getting is this hyperresponsiveness of the airway causing this increased inflammatory response, but here now, because this is inside the airway, it's going to prevent airflow from getting down through into the alveoli. And in particular, and this is a common misconception, when we think about people having asthma with that wheezing sound, it's actually easier to get the air in than it is to get the air out. And this relates back to thinking about the process of normal breathing, that when you breathe in, you contract muscles. So that process is strong. But when you exhale, the muscles are relaxing. So it's actually hard to push that air out. It's much easier to get it in. And so when we look at manifestations of asthma, we think about that wheezing that can intensify and get worse and worse as the airway becomes more and more restricted. But it can present in other different ways as well. So it may just feel that the chest is tight, that you feel that you've got shortness of breath, difficulty breathing. For some people, it can manifest as a cough. The cough could be a very dry, hacking cough, or it could produce mucus. It's not going to have any bacteria or anything in it, but it could be a productive cough because of all that mucus that's there from the inflammatory process. And you may even know somebody that has this. If they laugh really hard or they cry really hard, they start coughing. That can actually be a form of reactive airways linked with asthma as well. And then, of course, as the airway gets more and more restricted, I shouldn't say this in the obstructive chapter, more and more closed off, as the airway basically becomes blocked with all of that inflammation, you can end up hearing decreased breath sounds. In some cases, and this is why we get really concerned for people that have severe asthma, they can enter what's called status asthmaticus. Let me write that for you here. Which is a prolonged severe asthma attack, which means the airway becomes more and more closed off with that inflammation. You're not able to get air in. And unless you can alleviate that blockage, unless you can get rid of that, you're not going to get air in. And now you're entering a life-threatening situation. So someone who has a severe asthma attack is in trouble. It can be potentially fatal. And so this is why people who have asthma carry around with them a bronchodilator, right? Because intubating is not going to do anything. Intubating goes for the upper airway, but the problem here is in the bronchi and the bronchioles. Remember, that smooth muscle that's there is causing the airways to constrict. So you need a bronchodilator to open up the airways. And then people that have asthma usually are on some sort of a steroid to try and reduce the inflammation as well and prevent it from becoming as severe. But if they can't get to an inhaler fast enough, or if that inhaler isn't working because they've been exposed to something that's so severe, it's potential for an asthma attack to be life-threatening. So then we get to the part about chronic bronchitis and emphysema, COPD, our big topic for this unit. So we're going to start with chronic bronchitis. And chronic bronchitis is predominantly associated with smoking, but it can occur in any situation where you have a person who's consistently developing respiratory infections. So maybe they're immune suppressed, for example, or maybe they're an asthmatic, or something that has caused them to get a lot of respiratory infections throughout their life. Because this is an inflammatory disorder. It's ending in itis, right? So anything that's going to irritate the respiratory tract for a long period of time can cause chronic bronchitis, but we typically think of this as being associated with smoking. So here, it's important to pay attention to all of the B's that you can see. So chronic bronchitis, you've got the B in chronic bronchitis. This is type B COPD, blue bloater. So in this type of COPD, what happens is you basically have chronic inflammation of those airways, the bronchi, and in some cases the bronchioles as well, as a result of something like smoking. That chronic inflammation can lead to the formation of scar tissue. You get excess mucus being produced because of all of the irritation that's there. So you would expect somebody who has chronic bronchitis, for example, to have a productive cough. And it says here that it's irreversible when paired with emphysema. This is from your textbook. And here I would beg to differ a little bit, because once scar tissue has formed in chronic bronchitis, that's irreversible as well. And so if you don't yet have scar tissue that's forming, then it's not going to be a problem in theory, because it's still a reversible situation. So I don't think it has to be paired with emphysema for it to be irreversible. It's just irreversible once scar tissue is present. So for me, chronic bronchitis associated with smoking is an irreversible disorder. It tends to affect older adults, of course, because it takes a while for that damage to occur in the long term. So as a result of all of that inflammation that's happening in the lining of the bronchi, you get the scar tissue that forms, which here it says this is right from your textbook, right? So this to me is irreversible as well. So it goes through a little bit about the inflammatory process. You're getting an increased number of goblet cells there, so this is causing that excess mucus to be produced, especially if you're a smoker, because you're getting all that particulate matter in there. And so as a result, that's trying to trap all of the smoke particles that are in there. But remember, mucus is made up of something called a mucopolysaccharide. It's a starch-like component and makes an excellent medium for bacteria to grow. It's like having a little petri dish in there. So you're at a risk for further damage by getting respiratory infections because of all that mucus being in there and bacteria getting trapped in the air that we breathe. You can end up getting a lot of respiratory infections as well. So the walls become thicker as that scar tissue forms, so the space that air can travel is going to be decreased, which is why this is considered to be an obstructive respiratory disorder. This is going to be associated with the development of pulmonary hypertension. So airflow is going to be, or blood flow, I should say, is going to be redirected to areas of the lungs that have a better source for gas exchange to occur. And if you remember, we mentioned when we did cardiovascular system about cor pulmonale, the development of right-sided heart failure due to respiratory disease. This is possible with chronic bronchitis. It's also possible with emphysema as well. So keep that in mind. That's with COPD in general. You can end up developing cor pulmonale. So the bronchial walls are destroyed. As a result, you get all of this mucus collecting, putting you at risk for respiratory infection, impeding gas exchange from occurring because you're not getting good airflow down into the alveoli. So if you look at the manifestations, remember this was type B blue bloater. The blue references the cyanosis that can happen as a later sign of chronic bronchitis. And then the bloater part refers to the fact that if a patient has only chronic bronchitis, they tend to be overweight. This could be as a result of accumulating body fluids. That could happen because of the right-sided heart failure, but also because when you're having poor gas exchange, you end up slowing down your metabolism. That can cause you to put on more weight as well. But those are more commonly associated with a patient that has chronic bronchitis. Usually, you have a patient that has both chronic bronchitis and emphysema, so you may see some overlap with the manifestations. But if we're looking specifically with chronic bronchitis, you're going to get a lot of sputum being produced because of that excessive mucus, so you would expect a productive cough, especially more severe in the mornings because everything's sat overnight. So it's going to take a while to clear. That nasty smoker's cough that you hear on people that have smoked for a long period of time, that's telling you that they're on their way to developing chronic bronchitis. So here, this is the figure from your textbook showing the blue bloater with the patient being overweight and the cyanosis, the same sort of things that we just went over on the previous slide. To diagnose this, again, you're going to look at not only the clinical manifestations that the patient's going to tell you about that you can see, but you may need to do chest x-rays as well to see changes within the lungs themselves. But pulmonary function tests are also going to tell you some of the major effects of chronic bronchitis. So you need to go back. Remember, these are located at the end of chapter 21 to look at what is being tested for in these pulmonary function tests. And so some of the changes that you see, an increase in the residual volume, remember that's the amount of air that is not used for good gas exchange, and a decreased forced expiratory volume because it's going to be hard to exhale. you're not getting much air coming out, and so as a result that volume is going to be decreased. Your blood gases are going to be different, so your CO2 levels are going to be elevated. That can be called either hypercapnia or hypercarbia. That's the vocab word for that. And then decreased levels of oxygen in the blood, hypoxemia, leading to decreased oxygen in the tissues, hypoxia. You can see changes on an ECG, especially as right-sided heart failure begins to develop. And in many cases, you'll see an increase in red blood cell production, secondary polycythemia, because of those low oxygen levels as well. Remember, the R/T stands for related to. So the other type of COPD is emphysema. So this is type A, and we refer to it as the pink puffer. And I'll come back to that in just a minute about why we use those words. So this is in a completely different location in the respiratory tract. This is not in the bronchi. This is down in the alveoli, where the alveolar walls have been destroyed. So they're gone. So the air sacs become dilated, so you don't have as much surface for gas exchange. These walls are gone. So there's no scar tissue that's there. They're just no longer present. Remember that scar tissue is associated with inflammation. That's chronic bronchitis. So those air sacs become enlarged. Once those walls are gone, we can't make new ones, so that damage is irreversible. And as we mentioned already, it's often associated with chronic bronchitis. I put a few pictures in here. I'm sorry, there seems to be some overlap between the title and the pictures in this particular format, but you can see that on the picture on the left, the great big openings inside the lung that are there, you shouldn't be able to see those. Remember, alveoli are microscopic. So this tells you that those air sacs have become dilated as a result of emphysema. And the patient here on the right has this barrel chest that you can see associated with emphysema. When air becomes trapped inside the lungs, then what you actually get is an increase in residual volume, which actually causes an increase in total lung capacity, and that's characteristic for emphysema, not chronic bronchitis, but emphysema. The main cause for emphysema, just like chronic bronchitis, is smoking. More than 70 packs a year, so that's more than 1 pack a week. Think about those people that you know that smoke a pack a day, how much damage that they're actually doing to their lungs. But you can get this from living in areas that have high air pollution. You can have this by working in certain jobs that expose you to a lot of particulates in the air. And there's also a genetic situation, alpha-1 antitrypsin deficiency, that can result in emphysema as well. So what happens in emphysema, and in the case of smoking, this triggers this process where you get a release of these enzymes, proteolytic enzymes. So they're destroying proteins coming from the white blood cells. And these enzymes are now attacking and destroying the walls of the alveoli. And so we lose that surface area for gas exchange. They can actually, now these enzymes can get into the lung tissue themselves outside of the airways. That's the lung parenchyma, and cause problems as well. So as a result, we decrease the availability of surface area for gas exchange. That affects the capillaries that are available in order to do the gas exchange as well. We lose the elasticity of the lungs. So remember, that's important in helping us breathe out, is allowing those lungs to recoil and push that air out as part of the natural process. That can be difficult to do in emphysema. So I had somebody once describe emphysema to me as the equivalent of trying to breathe through a coffee straw. It's hard to get the air in, but it's certainly hard to get significant amounts of air back out, especially when you don't have the strength of the muscles to be able to do that, and the elasticity of your lungs is gone as well. So the air becomes trapped in these alveoli, and you get kind of like what are these little sort of blisters or bubbles that form, called blebs and bullae. Blebs are small, bullae are larger, that then eventually can rupture and lead to those spaces that you saw in that picture that I put up previously. So you can see here, instead of having lots of small little alveoli with lots of surface area, you can see that these air sacs have now been distended. So in terms of manifestations, these patients, if they only have emphysema, they tend to be thinner because it takes a lot of effort for them to breathe. And so this is where the pink comes from, because it takes a lot of effort for them to breathe. They actually tend to look a little bit more flushed. It takes more calories for them to do that, so they tend to be thinner. And they take on this pursed lips breathing sort of appearance that I'll show you in just a moment to try and be able to get that air out. In many cases, they may hunch over a little bit because that makes it a little bit easier to breathe as well. Use some of those other accessory muscles for breathing, the inter and intercostal muscles, to try and help squeeze the rib cage to move air in and out of the lungs. There usually isn't a cough associated with emphysema because it's further down in the alveoli, not in the actual tube, the tree part of the respiratory tract. And then because of that air trapping, you get the barrel chest. So here in this figure from your book, you can see the difference between someone who is a pink puffer versus someone who is the blue bloater that we just went over previously. And so remember, I like to ask the questions for chronic bronchitis and emphysema as a matching type question, where I'll give you a choice of, is this a characteristic of chronic bronchitis? Is this a characteristic of emphysema? Or is it something associated with both? For example, if I said caused by smoking, that would be both. Or dyspnea, that would be both. But if I told you presents with cyanosis, well, that's blue bloater, that's chronic bronchitis. Versus if I told you that the walls of the alveoli are destroyed, that's emphysema. So you've got to be able to make sure that you can match the characteristics with the disorder, and then make sure you know the features that are common to both, like they're both obviously obstructive respiratory disorders. To diagnose emphysema, again, there's the pulmonary function tests. Again, increased residual volume and decreased FEV. But notice also here, increased total lung capacity. Chronic bronchitis, that was normal. But emphysema, it's going to be increased. And then you can see a lot of the changes in the lung under chest x-ray as well. You can start to see changes in ECG. It doesn't show it here, but keep in mind this is also a chronic respiratory disorder that can also lead to pulmonary hypertension, which also can lead to cor pulmonale as well. So it mentioned it on the slides for chronic bronchitis. It is also true for emphysema as well, that you can end up with right-sided heart failure as well. It says mild decrease in oxygen, so these patients are able to get air in. The alveoli, that are there, still doing gas exchange, but you will eventually get less and less oxygen availability as more and more of those alveoli are destroyed. And eventually your CO2 levels will go up as well. So you would expect to see elevated CO2 or hypercapnia present for both emphysema and chronic bronchitis, especially in later stages. The final disorder I have you look at for this chapter is cystic fibrosis. Cystic fibrosis is an autosomal recessive genetic disorder. So this means autosome, it affects men and women equally. It's recessive, so you need 2 copies of the defective gene in order to get it. You can see it's the most common genetic lung disease in the United States, and it has a very reduced life expectancy. As you can see here, the median survival age is 31 years, because as you'll see, this affects the exocrine glands and ducts of the body, which aren't just present in the respiratory system, they're also present in the digestive system as well. And for males also, it can affect the reproductive system as well. So it causes a lot of problems within the body. The defect is in the CFTR gene. This gene affects the chloride channels that are associated with these glands and ducts, and so therefore affects sodium and chloride levels in these channels and causes the secretions to become very thick and sticky. And so as a result, they block the actual passage of material through those ducts and then start to cause problems. So in the respiratory tract, you get all of this thick, sticky, tenacious mucus trapped inside the respiratory tract that can be very difficult to clear, preventing good gas exchange from occurring, and obviously a lifetime of not having good oxygen levels is going to impair things like growth and development. And then this also affects the digestive tract. So we're going to come back to this when we do digestive system and talk about its effects on the pancreas, because it'll block the pancreatic duct as well and prevent those enzymes from going out through the pancreas and going into the small intestine, which then impairs digestion. The pancreas has the ability to make enzymes that digest all types of organic molecules. So now you have a person who can't get enough oxygen and who has malnutrition on top of it. So this is what is these are why you see this decrease in survivability for this disorder, because the more severe that it is, you're not going to be able to have the building blocks in order to grow and survive as you get older and older. Clinical manifestations, obviously, if we're looking in the respiratory tract, so you're going to have a cough to try and clear out that mucus that's there as well, difficulty breathing. You're going to be able to, in some cases, hear that fluid inside the lungs as crackles as well. That mucus, like I mentioned before, is a great medium for bacteria to grow, so they often get a lot of respiratory tract infections. It can be very difficult to breathe, especially while they're lying down as well. And you can end up getting some air trapping as well. They can get a barrel chest similar to what you would see with emphysema. And then again, like I said, take a brief look at the digestive system components as well. We'll do that more within the digestive system as we see that the exocrine ducts within, especially the pancreas, are blocked by that thick mucus as well, leading to malnutrition and malabsorption. At the end of this chapter, it goes over in more detail about the pulmonary function tests, goes over the different components associated with spirometry, and can indicate to you what the different parameters are associated with those respiratory volumes that can be measured. So make sure that as you're looking at these different disorders, that you look at the pulmonary function tests and what those respiratory volumes are that are going to change in the different disorders within this chapter. Okay, so this chapter, obstructive respiratory disorders, things that are causing increased resistance to airflow, blocking the tube. Maybe look at asthma and cystic fibrosis as more minor disorders, and then the main focus being COPD, looking at chronic bronchitis and emphysema, being able to compare and contrast the two. What are their similarities and what are their differences?